Welcome to the Birmingham Medical News Doctor Talk podcast. I'm Steve Spencer. I'm the founder of the Birmingham Medical News. We started in Birmingham 20 years ago, 2005, and we're a monthly newspaper for professional healthcare newspaper for doctors, nurses, and hospital executives and administrators. We do this podcast in partnership with Kassouf & Company. Kassouf & Company is an accounting firm in Birmingham, been here over 100 years. They do great work with taxes, but also wealth management. They've got a fantastic healthcare department that just specializes in working with physician practices and professionals in all facets of their business. We have a sponsor. Our sponsor today, located in Birmingham, is the Azura Surgery Center. They're an outpatient surgery center that specializes in minimally invasive dialysis access procedures. They're here to preserve the functionality of patients' accesses for dialysis treatment. Now, for patients, the Azura team partners with your doctor to coordinate your vascular care. They also provide a wealth of patient education, which we think is very important. They also provide easy scheduling with same-day or next-day appointments so that patients don't miss their scheduled dialysis treatments. The Azura Surgery Center has a team of highly skilled physicians that are board-certified leaders in their specialties. That includes Dr. Vin Nguyen, who is a vascular surgeon with over 20 years' experience, along with 5 highly skilled, very experienced interventional nephrologists. This is probably one of the top vascular access surgery centers, certainly in Alabama. We highly recommend it. To get on with our discussion today, we're talking with one of the interventional nephrologists from that center, actually, Dr. Tom Watson. And before we get started, Dr. Watson, I know you've got a pretty long career. Can you just give us a little quick one on your background?
Absolutely. I went to medical school in Atlanta. I trained in New York City. I was did my residency and fellowship in New York City, and with a short stop in Atlanta after training, found a home here in Birmingham in 2008. With the Nephrology Associates, which is a practice now of about 16 physicians, and we provide every facet of kidney care in what I would call the central region of Alabama. Okay.
Well, tell us what you see today as far as the state of kidney disease in the U.S.
It can be frustrating for a nephrologist because we see a lot of misery with kidney disease. Approximately 8 to 10% of people in the world have some level of kidney disease. It's a bigger number than people realize.
Much bigger than I thought. Yeah.
Sure. And in many cases, it's a mild problem and can be low on a list of healthcare priorities. But in some, it can be a very significant problem, and even in those who are young. The main problem that we see is some percentage of that large number of people will get worse with time and develop kidney failure. Kidney failure requires a kidney transplant or dialysis, and there are approximately 600 to 700,000 people in the United States suffering with kidney failure. So the joke when I was in New York was that there was a Chinese restaurant and a dialysis unit on every corner. You just didn't see the dialysis clinics. So if you're driving around rural Alabama, almost every county has at least one dialysis facility. You just don't notice them. Yeah.
And one thing, and I don't want to get you off track, but you mentioned surgery or dialysis. I would guess there's probably a big waiting list.
There's a major waiting list for kidney transplants.
I would think so.
Absolutely, and it's one of those things. If I ever get an opportunity to be in front of any sort of public forum, I beg people to be organ donors. We probably lose about 50% of potential transplantable organs because families in their worst moment of their imaginable lives, when a loved one is dying, aren't ready to make a decision to share their organs. It makes sense that they're not, but if patients or people communicated to their families that they would want to be an organ donor if the worst that they could imagine happened. It would be so much better for so many patients who are suffering on dialysis.
Sure. And thinking about, you mentioned the families, what suppose you have a patient who I suppose has it a little further down the road in terms of, the disease. What does that place a burden on the family? I'm sure it does. But
Absolutely,
how? Yeah.
absolutely.
Yeah.
Kidney disease affects, unfortunately, it affects many of your organ systems. Patients with kidney disease develop more heart disease than the general population. They have a higher risk of and susceptibility to infections. So, for example, they did worse with COVID than the general population.
Okay.
And then it just requires a lot of doctor's visits. I think if I have one doctor's visit that I'm having a bad month. Whereas somebody who's a dialysis patient has 13 trips to a dialysis facility per month. And that doesn't. And then they have other doctor's visits, or they visit the surgery center you mentioned in the sponsorship commentary. So that's you're looking at.
So basically 3 times a week, it sounds
easily
like.
3 times a week. Easily 3 times a week. That's right.
And then I'm sure because you said there's so many comorbidities, they've got plenty of other doctor appointments.
Absolutely.
So go ahead. I'm sorry.
No, you're exactly right.
Yeah.
So even if you just think about the fact that someone has to give up half a day, 3 days a week for their dialysis treatments, that person usually can't work. We can get them to still be able to work, but often they can't support themselves. So then they have to be able to just get something as simple and frustrating as getting a ride. To be able to get to dialysis or to be able to get to their appointments. It can be such a nightmare and a financial burden, and then you have their children having to take a day off work just to get them to an appointment that they need to get to. So it's extremely burdensome.
And what I'm just thinking about, if you have a family, you have a spouse, kids, parents, maybe so, but I'm sure you run across a lot who may not have a family. If somebody's never married, that's got to be really hard.
Very, very, very difficult. Yeah. And it's
especially supporting themselves if it can't work. I'm sorry, you go ahead.
You're exactly right. No, you're right on target. Just to imagine that I can think of my lady right now who does not have any family support, and it's such a struggle for her simply to get to dialysis. And that struggle is not just logistics or physical, it's actually emotional too. She's by herself and having to drag herself to a dialysis treatment 3 days a week.
I mean, that's really hard.
Yeah.
So obviously, like you said, a lot of appointments.
Yes.
Now, I know that in the last, I don't know how many years, but I know we've gotten a little bit into home dialysis.
Absolutely.
And what's the status of that?
It's interesting. The way this happened in the United States is different than it did in other countries. There are several countries in the world where home dialysis is the majority of patients.
Okay.
In the United States, based a lot on just the way that we did things became the way that we do things. People, the majority of patients do dialysis in a center, as I've described, 3 days per week. 10, 15, or 20%, depending on your geography, of patients will choose to do dialysis at home with the support of a person like me or a nephrologist who helps educate them and support them and train them to provide their own care.
Okay.
At this time, there's not a means of having a staff member or a nurse go to someone's house and provide the treatments for them in their home. But it is a burden, but it's not hard enough that a patient can't be trained to do it on his or her own. And then that provides them with much more freedom. Yeah. And they feel better.
I'm surprised it's only 20%. Is that because a lot of people just don't know they can do that? Or is there...
There are many factors for that, but some of them are fear. Truly.
Okay.
Patients are afraid to take a machine home and provide themselves with what they view as a life-sustaining therapy and be afraid to mess it up.
I can see that. And you feel comfortable if there's a nurse or somebody that you know is an expert.
Correct.
I can see that.
And there are a lot of rumors about it, too. There are. It is true that a patient doing home dialysis can get some infections, but so can a patient doing dialysis in a clinic.
Center. Okay.
And it's work. I mean, it requires you to take care of yourself, and it requires you to do it every day, which is different than the in-center dialysis. Or at least one of the types of home dialysis is generally done every night while you sleep.
Okay.
Which, by the way, sounds great to me, because then I have my days and I can still work. Yeah. And I can generally feel okay.
Right. Yeah, that would make a big difference in somebody's life, because I mean, not being able to work unless you've got family support could really be hard.
Absolutely.
Now, early in the conversation, you mentioned that a lot of these people have to go to doctors for other things, so there's a lot of comorbidities. Can you tell me not only what are some of the comorbidities, but why? Does kidney function affect other organs?
It does.
Okay.
So several reasons. The primary the most common cause of kidney failure or kidney disease in the United States and worldwide is diabetes.
Okay.
Diabetes ravages blood vessels everywhere. So patients with diabetes develop kidney disease along with heart disease, along with damage to the blood vessels in their eyes or their brain or their extremities. So you can lose sight, you can have very high rates of heart disease, heart attacks, congestive heart failure. You have what we would call high rates of peripheral arterial disease, or poor circulation to the feet.
Right.
And then even in the absence, though, of diabetes, patients who have advanced kidney disease because of some of the changes in their physiology also have, without diabetes, much higher rates of heart disease, stroke, congestive heart failure, and infections as well.
So it sounds like almost the person with diabetes, kidney problems are just one aspect of the diabetes in a way, right?
That's right. Approximately 30% of patients with diabetes type 2, which is the most common form, will develop kidney disease or kidney failure. And it depends a lot on diabetic control too. So if early on in their journey with the misery of diabetes, and I feel so terrible for patients who are diabetic, the better control they have, the less likely they are to develop some of those organ damage related problems.
Gotcha. Well, so we've got all the comorbidities. What about complications
of kidney failure?
Yeah. Exposure to they're in and out of hospitals.
Yes, they certainly have a high, patients, especially dialysis patients, but those with advanced chronic kidney disease as well, much higher rate of hospitalization, and as I said, for those other comorbidities, generally speaking. And when being cared for by incredibly intelligent and well-intentioned non-nephrology physicians, some challenges arise related to even just something as simple as medication dosing. For example, a patient on dialysis who develops shingles might be given a prescription by mistake of a full dose of a medicine of an antiviral medicine to treat the shingles. And can't tolerate that dose, and it can even potentially be a lethal dose of medication if you're not careful. So they're always just one step or one little bump in the road from just being back in the hospital.
Really bad situation. Yeah. What about what are the various reasons for kidney disease?
Number one is, as I said, is diabetes. Number two would be high blood pressure. And then we get into some combination of autoimmune diseases. A common one that's known amongst the general public would be lupus, but there are a number of others. And then there are some genetic diseases as well. I can't necessarily say. I used to say the most common is an inherited form of polycystic kidney disease, where the kidneys are replaced by cysts, just bags of fluid, and they go from looking like what I'm sure, to be a kidney appearance, to looking almost like a bunch of grapes. Huge. They get very, very large, and they develop kidney failure depending on the severity of their disease at various stages of their life. One other genetic cause that has been more recently discovered, and thankfully is being studied right now in terms of potentials for treatment, is a gene that a particular mutation of a gene called apolipoprotein 1, apolipoprotein 1, or ApoL1, which is seen mostly in African Americans or those of West African descent.
Okay.
And that confers at times a tenfold higher risk of kidney failure than the general population.
Okay.
It's just terrible, and we're hoping for some treatments to come down the pipe.
Yeah, because I'm just thinking if somebody has that gene, there's nothing they can do, right?
Not right now, but there are some early trials of therapies being tested for treating patients to prevent development of kidney disease. And
are there any new treatments?
Sure.
Okay.
Yeah. About 10 years ago, I would have told you that nephrology is the same now as it was 25 years ago. And the sad thing, and I don't want to get into any sort of social commentary here, but kidney disease research lags behind the big ticket diseases, I guess we could call them, like heart disease and cancer. The American Heart Association and the American Cancer Society appropriately get a lot of financial support for research, and they've made some incredibly wonderful advancements in treatment of heart disease and cancer. Things have changed so much since I went through training, and it's very exciting. Kidney disease has lagged behind in many ways because of a disparity in funding for research, but there are some new medicines that have become foundational for patients with kidney disease, early and late stage kidney disease. They started in the 90s. There were medicines, ACE inhibitors and angiotensin receptor blockers. In the 1990s became standard therapy for patients with kidney disease. And then in the last 5 to 10 years, some new medications especially for diabetics, but also for anybody with kidney disease, especially those who have any protein in their urine. The medicine's called SGLT2 inhibitors. The trade names are Farxiga and Jardiance are the two most commonly used ones. Also demonstrating incredible improvements in or prevention of worsening of kidney disease, but also preventing heart-related complications as well, and hospitalizations and death. So those two medicines, the ones from the 90s and the more recent ones, are becoming sort of the foundation of care for patients with almost any kidney disease. There are two other classes. One would be the weight loss drugs, right? The injectable weight loss drugs that everybody's using for, sometimes using inappropriately, I suppose, but most often appropriately, what we call GLP-1 agonists, Ozempic and Wegovy and Mounjaro. Those are all actually, we were concerned they might be bad for kidneys. They're not. They're
and
good.
Why are those helpful? Is it because just losing the weight? Is that it?
I don't know yet. It may be in part because of just losing the weight. It may just be partly that. But there's certainly demonstration of fewer heart attacks for patients that take those medicines, and less kidney disease or better kidney outcomes, we'll say.
It's interesting.
Isn't it? Yeah.
I wonder if, well, I guess you'll find out. I mean, I'm wondering if somebody's not only eating less, but maybe less appetite, drinking less?
Yeah. No, I mean, we were worried that they were eating or drinking less and they would have more risk of becoming dehydrated, which is bad for kidneys.
Sure.
So we really didn't know what was going to come of it. But
that's interesting.
Yeah.
And so wait, now we mentioned the one from the 90s. And the one from about 5 years ago, and now you're talking about the weight loss drugs. Did you say, was there a fourth?
Yeah, there are several more that are coming down, and then even some more advancements in therapies for a disease I haven't mentioned yet, but it's a worldwide common type of kidney disease called IgA nephropathy. There are some new medications that have been. It's just it's a type of kidney disease, and we don't understand all of the reasons why it exists, but it does, and it's historically been very difficult to treat. But there are some new medicines that are being tested and showing some promise.
And this IgA, how does that? Okay, so we know that, if I understand it right, this is all new to me, but so sounds like, I think, I forget the percentage, but a lot of patients, it comes with diabetes.
Correct. That's right.
And you mentioned the genetics.
Yep.
Now, this last one you mentioned, is that genetic or did?
Probably in some ways genetic. I'm not sure. We don't have exactly the answer as to why everyone that develops what we call IgA nephropathy gets it.
So they don't know why. They don't know if it's lifestyle, or they don't really.
It's certainly not lifestyle. It is a thing that happens at this point. Probably primarily genetic, but it's not. it's not as if we found the gene that confers that disease on patients. So, but regardless, it is. I wouldn't call it a rare disease. I see it quite often, but thankfully there are some medications coming out to treat it.
Okay. The medications for that, do you know a time frame when they may be out?
They're being studied in phase 2 and phase 3 trials right now. And in fact, there are some that have been approved in the past several years, FDA approved in the last year. There was a class of medicines that was approved, a particular medicine that was approved for treatment specifically of IgA nephropathy.
Okay.
So, we're making some strides, thankfully.
Okay. You'd give me some notes that are real helpful, and you also mentioned lupus.
Yeah, lupus is an autoimmune disease that can attack any organ in any part of your body.
Okay.
Because it effectively attacks DNA, which is in just about every cell except your red blood cells.
I didn't know that. I'm familiar with lupus, but I didn't know it attacked DNA.
It attacks any cell with DNA, right? And sometimes non-DNA cells.
Okay.
But the one of the worst complications of lupus is kidney failure. And it can be...
It's just attacking the cells in the kidney?
Absolutely.
Okay.
Absolutely. It's a very inflammatory process in the kidneys.
Okay.
And can develop from like a lightning strike, go from normal kidney function to very, very, very bad kidney function in a hurry.
Oh, wow. Okay.
So there are definitely some advancements that have been made in treatment of lupus nephritis.
Okay.
Nephritis being the inflammatory condition that lupus causes in the kidneys.
Okay. And you had also mentioned in some of the notes you gave me about transplantation, the state of that right now.
Absolutely.
I know we talked earlier about how there's always a big waiting list.
Absolutely. Talk about transplant. It's exciting. I mean, I say this to patients on dialysis that I wish they didn't have. Obviously, I wish they didn't have to do it.
Yeah.
And that we could provide transplants for all of them. And there are, I'm going to say 2, and then the potential things that everybody's seen in the news that are coming in the future. But 2 main ways to get a kidney would be one from the waiting list that we've discussed, which would be from a deceased donor, someone that has had a heart attack or a stroke that has rendered them dead, but their organs can be transplanted. So that is a deceased donor kidney. That is what you wait for on a waiting list.
Yeah, right.
Generally speaking, in Alabama, that wait list, it changes with different things, but it's several years.
Okay.
3 to 5, depending on your blood type and other things. Then the other way is to find someone who is willing to donate one of his or her kidneys to you.
Okay.
That can be a loved one, but it doesn't have to be. In fact, I've got a great story I tell all the time of a man who's my patient who was very close to starting dialysis, had an enormous fear of doing so, and was basically unashamed to ask anybody.
Okay.
And a man came to his house to fix his washing machine.
Oh, man.
And the washing machine repairman ended up giving him a kidney.
Wow.
It was incredible.
That is pretty amazing.
It really was incredible. And he's lived it's been 10 years since then.
And the 2 of them must have had a good conversation.
I know.
They must have really connected.
I know. Those are great stories. The fact is that anyone can donate a kidney to anybody. There are some hurdles, including blood type and the recipient, the patient that is getting a transplant, has to be healthy relatively. Despite kidney disease. We don't want to make somebody worse by putting them through the stress of the surgery plus all of the immune suppression and their ability to handle all of that stuff. And then the donor needs to be healthy. What we do not want to do is cause harm by trying to fix someone else.
Sure.
Without a doubt, they go through some harm because of surgery to donate the kidney, and they're out of work, which can be a significant problem for some, but they can be out of work for a month or 6 weeks. There's discussion in Washington about a way of supporting donors during that time when they're off work, so that they could not view that as a financial hurdle.
That would make it, because I would think a lot of people, hard to take off work for 8 weeks.
Exactly.
Exactly. And so that would probably open up some doors. I mean, more people might consider it.
Absolutely. Yeah. And you've heard of these maybe donor chains. So an example would be a husband who wants to donate a kidney to his wife.
Okay.
The husband's got type B blood. The wife has type A.
Okay.
you can't donate. But out there's another
somebody with type A,
with the opposite,
yeah,
right? And so so effectively there's a donor registry, several of different ones throughout the nation and statewide that that transplant centers use to effectively match up donors with recipients. Everybody goes to sleep, the kidney goes where it needs to go, and people wake up happy. So those are pretty just logistical challenges.
Yeah.
But they work great.
It's a great idea.
Yeah.
I don't know. That's a great idea.
Exactly.
Yeah.
And then some of the more exciting things that we see in the news recently are these pig transplants.
Yes.
Xenotransplantation.
Right. Yeah.
And that, it's enormously exciting because it's showing the promise of what it could look like to have what we could effectively view as an almost unlimited supply of organs to be able to transplant.
Yeah, then waiting lists are a thing of the past.
Exactly. And that's well down the road, but they've at least made some significant strides in proving that a pig kidney that's been genetically engineered to be able to be transplanted into a human could survive the first 2 or 3 days at least of the, and then the law of unintended consequences is immutable, so we still don't know what we don't know. There will be more to learn, and I'm certainly not an expert in that part of nephrology.
And tell me if I'm wrong, as this is really vague memory. Am I right about this? Are they looking at a way to actually grow the pig kidneys? Is that right?
Yeah, there's a couple ways they can do that. So the primary way I believe right now, and again I'm not the immunology expert that to answer this question expertly, but you either create a pig that does not any longer have the immune system flags or antigens that would trigger a person's immune system to reject it. Okay. So you genetically engineer that kidney to be just inert in terms of a recipient's immune system. And that's one way. Okay. Another way that I've heard about but not seen in practice is to take a person's stem cells, stimulate a stem cell or however they would do this in a lab that I don't understand, but stimulate that stem cell to grow into sort of a immature embryonic sized kidney, implant that into a pig embryo, and let the pig grow up. And then once the pig is of appropriate size, you harvest the kidney that was created out of the stem cells of the person that needs it, and you transplant that back to the person, and it's their own DNA. Okay. Does that make any sense?
Yeah. It does. Yeah, it absolutely does.
I haven't seen it happen. I think that's the general idea of what some of the ways they're looking at this.
20 years ago, that would have been science fiction.
Exactly. It still feels like science fiction, honestly.
Yeah. Can you imagine 20 years from now what we're going to be looking back on and what we'll be looking out at?
I know. It's very exciting.
It is. It is. And you mentioned they're better immune system regimens.
I think patients, they're always looking for they're doing a great, and by the way, we have the enormous benefit of, in the Birmingham area, being so close to one of the country's and the world's best transplant centers. So and they're doing some of the most advanced xenotransplantation research there, and they just do a great job with the transplants themselves. So what a benefit is for all of my patients who are close by. But they and every other transplant center and immunologist in the world is trying to improve upon our ability to prolong the life of a transplanted organ, while reducing the side effects that those medications can have on the patient taking them. So reducing the chance that they would have exposure to certain infections, to find a way for the immune system suppression to really only stop the rejection of the organ without damaging any of the rest of the person. Right? Yeah.
And as I mentioned earlier, you gave me some great notes. I mean, really helped me a lot.
Cool.
And in that, you also mentioned new payment models.
So that's interesting. If you think about what I mentioned earlier, where dialysis patients have so much exposure to healthcare, every single exposure comes with a cost.
Yeah.
Right.
Yes, of course.
So patients with kidney disease are some of the most expensive to the medical system of anybody.
Okay.
And the reason is not just having to pay for dialysis, but it is the increase in hospitalization rates, the increase in needs for surgery, the increase in heart disease, higher rates of cancer, and need for chemotherapy.
And heart disease and cancer are really expensive.
They are, yeah.
Yeah.
And the fact is, patients with severe kidney disease in particular have much higher rates of those problems. So when if I'm an actuary looking at Medicare expenses, I look at this disparity where this smaller-ish group of patients have this enormous amount of cost.
Right, sure.
So Medicare is trying to find ways to improve the lives of those patients while altering the way they pay physicians in such a way that those physicians are better incentivized to keep their patients off dialysis.
Gotcha. Right.
And
Makes
to
sense.
get them to a transplant. If this is not how I or any doctor I know operates, but if my motivations were purely financial, I would want more patients on dialysis.
You would?
I would.
Okay.
If it was purely
Gotcha.
financial.
Gotcha. Understand.
Right?
Okay.
So Medicare is trying to change that paradigm so that our incentives align
Gotcha.
with what's best for the patient. Isn't
Sure.
that what we want?
Yeah.
Now, again, before that, that's not what we were doing anyway.
I understand.
We
Sure.
never put patients on
Of
dialysis
course.
for the money.
Yeah. But the incentive is
It
really
exists.
a big help.
It existed, right?
Yeah.
So now they're trying to through a program that our practice is involved with, and in partnership with a different company that's called Evergreen Nephrology.
Okay.
The federal government is putting the financial risk of a patient's healthcare spend in the lap of the physician,
Okay.
so that I can help that patient get everything he or she needs and not more.
Okay. Okay.
Try our best to keep the patient from going to the hospital, to reduce unnecessary visits to an emergency room or unnecessary hospitalizations that could have been handled as an outpatient, to improve if they have to transition to dialysis, to improve that transition so that they stay out of hospitals, so that it's safer and that they have a better outcome and they have less heartache. And I mean, in a way, if you think of every dollar spent on healthcare, every dollar spent on healthcare represents some sort of misery or suffering for a patient and a family.
Sure.
So if we actually do improve patients' lives, keep them out of the hospital, and reduce the amount of suffering and cost, everybody wins. Right?
Yeah, absolutely.
So those payment models are really just focused on incentivizing physicians to focus, to be purely patient-driven,
Right.
in terms of.
And that makes me think of something. So, along exactly those lines. So, if you have a patient who's, they have kidney problems, but they don't yet need dialysis, what do you do? How do you help that patient? I guess slow the progression of the disease,
Absolutely.
or not let it progress too fast. Well, what do you do?
So
what are some of the,
Yeah, the medicines I mentioned, those two foundational, the Farxiga and Jardiance, along with the ACE inhibitors or ARBs, those are primarily medication management. For a diabetic, we focus very heavily on making sure that their diabetes care is as good as possible.
Okay.
Although sometimes not too good. You don't want them having low blood sugar events, but a particular target for diabetes control, blood pressure control is very important as well. To get there, to get to diabetes control and blood pressure control, often patients need something that's hard to get, which is dietary support, dietitian
See, that's
support.
what I was going to ask you.
Yeah.
I was going to ask you if you were getting, in lifestyle. Yeah,
Absolutely.
Yeah.
So,
okay. And I would think not only diet, but exercise too.
Diet, exercise, absolutely.
Okay.
If and when possible. And it doesn't have to be getting in a gym and lifting a huge amount of weight, and it doesn't have to be running a marathon. It can be walking.
Sure.
In fact, walking's wonderful.
Yeah.
Walking, stretching, and staying active is so important. And then helping patients with dietary control to control diabetes and high blood pressure, and educating them on what foods to avoid, what foods to. And it's interesting. The internet will tell I see patients all the time who have learned from the internet what they think they're not supposed to eat and not supposed to drink.
Okay.
And often it's wrong.
Oh, man. Okay.
So, but that's okay. I mean, the internet exists for so many good reasons, but it has its own downside as well. So yes, we're leaning in on education. Another major problem with patients who have kidney disease is, I mentioned earlier, fear. But mental health is an enormous problem for patients with a progressive chronic disease.
Because the fear, anxiety. And one thing, just backing up a little bit.
Yep.
So when you're working with a patient on lifestyle, and you've obviously got to encourage exercise and the right diet, is there a way that you try to keep up with them on that, or somebody in the practice?
Yeah. So, well, I mean, our hope is to be able, if these payment models expand, that we can be able to provide in-home care and support and dietitian education.
Because I'm just thinking, so many people may start on an exercise thing, which, like you said, walking's fine, or diet, and then they get off of it.
They don't stay. Yeah, exactly right. You're right.
Yeah.
It's a collaborative effort between. It depends a little bit on what stage they are with kidney disease, how severe it is, but a collaborative effort between us and primary care physicians, and us in cardiology. But yes, we do try our best to stick with them. Yeah. Two of the main things we target are with the diabetes and blood pressure control. It's hard to measure exercise. Right?
Unless
just have to
they
trust
got
what
like
they're
a
doing.
Fitbit or an Apple Watch, something
That's
like
right.
that.
That's a good point.
That you could really do it with that.
Get their steps in. Yeah.
I mean, I've got a friend. I don't have one that's got an Apple Watch, and he gets his heartbeat and every sleep cycle, everything.
I mean,
so it'd be great if people would.
Yeah. As you say that, my dad's cardiologist told him to get an Apple Watch, right? I mean, I'm sure cardiologists are doing that all the time.
Yeah.
So I haven't adopted any personal tech to try to monitor my patient's exercise yet, but I suppose
or even if a guy just got one of those simple step counter devices.
Sure.
Yeah. Because anyway.
Yeah.
Hey, one last question that actually just popped up as I was thinking. Okay. Do you think the rate or the percentage of people with kidney problems, maybe need analysis, is it increased in the last 50 years?
Yes.
Okay.
Definitely.
And then I would ask, why do you think that is?
Increase in diabetes.
But why?
Why that? Yeah.
Is it, I'm guessing lifestyle and diet, but
yeah, some of it's diet, some of it's weight, some of it's some of it's genetics.
Okay.
There are. I may be wrong about this, but we may be reaching a little bit of a plateau in the past 10 years or so.
Okay.
But certainly, without a doubt, the rates of kidney disease have been increasing.
Okay.
So that can be attributed to a combination of an increased rate of diabetes, which you can link to genetics and both genetics and what we can call cultural factors, as you said, or lifestyle-related factors. So it's not a problem that's going to get better soon.
Yeah. And I'm also thinking, the first McDonald's really started expanding in the 60s,
yes,
thereabouts. You think about what people ate in the 1940s. I mean, it was almost always a home-cooked meal with plenty of vegetables.
Yes.
So I'd assume that's got to be a
I very much believe so. I agree. I'd try to get and you can see it. You can measure those sorts of things in dialysis patients. You can tell which patients are eating. And the sad part is patients that have limited financial support and limited geographic exposure. These food deserts that exist, where the only thing you can get to is a convenience store with a bag of Cheetos.
Yeah, and also, as I think you mentioned, finances. Fast food is pretty inexpensive.
It is. It is. It is. Yeah.
So
but it's got its it definitely is. To your point, it's such a problem.
Yeah, I mean the grease, even that alone, and I'm getting us off topic. Did you ever see what was it called? Super Size Me?
Yeah, I haven't seen the movie, but I certainly have read about it. Yeah.
Oh my Lord! Oh boy, I did.
He passed away. The actor
recently.
Yeah, I think
in
so.
the last 6 months or so. Yeah.
So yeah, I'm not anti corporation or anything like that, but I would walk around with a no fast food T-shirt on all the time if I could for my patients.
Yeah. I mean, I've always thought that all these things kind of happen coincidentally with the increase in fast food.
And to a point, that may be true. Honestly, I don't know the answer, but it may be true. I think it might be. I have my own story with fast food from early in my career when I had a lady that I knew well, and we joked around all the time. And I was working on her with her diet and her blood pressure control, etc. And I came in to see her one afternoon, and she didn't want to talk to me. And I said, what's going on? What'd I do? And she pointed a crooked old lady finger at me, and she said, I saw you walk in here with a bag of Taco Bell. Don't tell me how to eat. It's the last time I've eaten Taco Bell.
Oh, man.
That
seriously?
Was 20 years ago.
Really? That's the last
Truly,
time?
that's exactly
That's pretty amazing.
Yeah, I had to give up fast food. I just couldn't be honest with my
That's
patients,
pretty cool, though. I mean, I could see you giving up for several months, but to give it up 20 years,
for good, yeah.
I rarely, very rarely, I mean, literally maybe once every 6 months.
Yeah.
I actually dropped soft drinks just going on 13 years now.
Yeah, wow, yeah.
And I used to drink a Coke every day.
All the time.
Yeah. Anyway, but hey, thanks a lot.
Yeah,
been
pleasure.
Really interesting for me. 90% of what you had to say was news to me. And
cool.
Like I said, it opened up some different thoughts. But thanks a lot.
Really
and let's hope that some of these new treatments will continue to roll in.
Absolutely.
All right.
Yeah, great.
Yeah.
Thanks for your time. It was really fun.
Yeah, absolutely. Yeah.